Okay, what about facial numbness? So you have dermatomes from the different divisions of the trigeminal, the ophthalmic division, the maxillary division, and the mandibular division here. And they enter the trigeminal ganglion into the pons and descend all the way down, way past the medulla into the spinal cord before it crosses up here. That's the trigeminal lemniscus. Okay, so it crosses way after everyone else has crossed, which is the reason why you can have numbness of one side of the face and numbness on the opposite side of the body because of this arrangement. Okay, if you have a peripheral nerve lesion, it'll just be affecting the divisions here. Okay, for only to preserve the V3 division, it has to be a peripheral problem, either in the supraorbital fissure, because that's where both the V1 and V2 enter, or in the cavernous sinus. Although it should be correctly cavernous sinus problem, because they will separate. The V2 will go into the foramen rotundum. If it affects all three divisions, then it might possibly be within the Meckel's cave, at the skull, at the base of the skull. Or it could be in the medulla, but this would entail finding other long tract signs like a weakness, a numbness on the opposite side of the body, if you're invoking a brainstem problem. Okay? So that explains why the numbness only extends until this part of the ear. The remainder of the ear and the angle of the jaw are spared. Okay. The moment these are included, it means the patient is not telling you the truth. Okay, corneal reflex. Normally, you feel a foreign body sensation when something goes into your eyes, and the natural reaction is to blink very fast. So the same thing is replicated, and you instruct your patient that you're going to do this. Okay, you instruct them to look to the other side and swipe with a wisp of cotton like this. So a corneal reflex is a sign that the V1 dermatome is not working. Okay, so the normal reaction is to grimace or to blink. If there is no reaction, that means there's a problem in that person's corneal reflex. Okay, so that's this just illustrates the dermatome where that corneal reflex goes. So it's a part of the V1 dermatome. So it has to travel all the way down into the spinal cord and then crosses to synapse with the facial nerve here, which leads to the blink reflex. So the sluggish corneal, you need to differentiate from a trigeminal problem versus a facial nerve problem by testing for the facial nerve. That's the only way to find out. Okay, jaw deviation, I've mentioned this earlier. The direction of the jaw should be midline protrusion. When you move the jaw forward and backward and right and left, the strength of the jaw should be equal. Only a peripheral nerve can knock this out. Okay, and these are the different motions of the jaw. You'll go into OS 204 for this. Okay, that's normal versus abnormal. It will deviate towards the side of the weak muscle in terms of the jaw, which is peripheral. So in this case, the weakness is on the left jaw. Okay, so we report this as the jaw deviates to the left side. Okay, again, illustrating the 50-50 split of the corticobulbar fibers to explain this. And the presence of atrophy and fasciculations gives it away as a peripheral nerve or lower motor neuron lesion. Okay, I mentioned the hyperactive jaw jerk reflex. This just tells you that there has been a compromise of both cerebral hemispheres, probably through a past lesion, to explain a hyperactive jaw jerk reflex. Okay, this just illustrates what I showed you earlier. the reflex arc of the jaw jerk reflex. Okay, if it was not clear in the first lecture, it should be clearer in the illustrations here. Okay, so hyperactive jaw jerk.